Hi, my name is Michelle Arias. I'm a med student, and in this video we're going to talk about the infective endocarditis. So, to start, we have the definition and the concept. It is an infection of vascular structures like the heart valves, the endocardium, the large vessels, and it is produced by a bacteria, fungi, and viruses. It can start in the skin, in the oropharynx, in the genitourinary or respiratory tract, and it is classified according to the evolution, the causal agent, or the activity. It can be acute, subacute, or chronic, and the gram-positive coconuts are responsible for the 90% of the cases. We have some risk factors, like in the children, the congenital defects of the cardiovascular structures, the prolonged use of IV catheters, the use of antibiotics, and in adults, we have the degenerative valve disease, the IV drug use, or the previous valve replacement. We have a clinical picture. In the classic picture, we see fever, anemia, hemorrhagic thrombotic manifestation, and less frequently neurological disorders. We can see splenomegaly and murmurs. We have cutaneous manifestations like petechiae, red spots on the retina, and we can see the genoise injuries in the palms of the hands and soles of the feet. Also, we can see a kidney disease. So, the diagnosis. It is suspect in the presence of fever in a patient with risk factors, and the diagnosis is evident in patients who present all or most of the classic manifestation, and there are bacteremia or funginia, active valvulitis, and peripheral emboli. And for the diagnosis, we use the criteria, and this includes major criteria and minor criteria. When we have two major or one major plus three minor criteria, we can say that it is a definite IE. But if we have one major plus one minor or three minor criteria, we say that we have a possible IE. So we can also use the laboratory and cabinet studies, like the blood culture, the hemathic cytometry, the rheumatoid factor, the general urine test, and the echocardiogram. So for the treatment, we have an empirical treatment, and when the problem is in the native valve, we use penicillin, G-sodium plus gentamicin sulfate. And when the IE is caused by S. aureus, we use dicloxacillin or cephalosporin of first generation plus gentamicin sulfate. And we can also use vancomycin in patients who are allergic to penicillin. When the IE is associated with valve prosthesis, we combine it with gentamicin or rifampicin, and the surgical treatment is for patients with persistent fever and bacteremia of more than 7 to 10 days after antibiotic treatment. In the last, we have the prevention measures, and these are going to decrease the ability of the organisms to adhere and multiply. So it's all. This is the bibliography. So thank you.